Hello and welcome to the Gateshead Health Cancer Patient Podcast. I'm here today at the AK Studios in Gateshead, and I'm pleased to have some of the team from Gateshead Health with us today, and we're talking about the topic of male breast cancers. So, Ross, do you want to kick off?
Absolutely.
Ross is one of our new consultants. He's a new dad.
Yep.
So, a little bit tired this morning.
Absolutely. Lots going on.
Lots going on.
Yeah. I'm a breast surgeon, and I'll be starting at Gateshead Health as a consultant at the end of the year. In the meantime, taking a bit of time to enjoy being a new dad, and off for a couple of months to go and learn some new skills, which I'm hoping to bring back to Gateshead.
Oh, that's fabulous. We also have Emily, who is one of our breast care nurses.
Yeah.
She is actually one of the most compassionate nurses I've ever met.
Thank you.
Honestly, there's nothing this woman can't do, because the crafts and things like that you do as well alongside that, and being a mother and doing a master's, so very busy woman. But I'm glad you've been able to come in and talk today. So what really kind of got you involved in the subject of male breast cancers, Emily?
I think it started, Caroline, when I'd been working in the breast unit for a little while, and I was getting, my caseload and more patients, and I had my first ever male breast cancer patient, and I was a little bit like, what do I do? And it was my blind spot, and I think really I shouldn't have had a blind spot. Really, I should have known more about it, and I should have really been more equipped. And the patient that I had, he really struggled with it, and he found it really, really hard. He felt emasculated. He felt like he had a woman's disease. He wasn't a man anymore. He was obviously scared because he had cancer, but I think because he had breast cancer, he was thinking, but how can I get breast cancer? I'm a man. And it was really tough for him. And, the initial diagnosis was really tough for him anyway, but then he also struggled with body image issues. He had to have a mastectomy, which meant he lost his nipple. And I think a lot of the time we always think breast cancer, mastectomies, reconstruction, but we kind of forget about men. We don't always think about, he's going to have problems with body image, he's going to be worried, he's going to be upset. And then I really struggled to find support for him, because there wasn't really a lot out there. And I kind of thought, this isn't good enough. So I tried really hard to find as much as I could. And then after a few months, I started thinking, I thought, if there isn't stuff out there, maybe we need to create more within our service to make it better. And then the lovely Ross came along, and he'd obviously, came around to it the same as I did. He didn't realise that I'd already started doing an audit, and then things kind of progressed quite quickly because there was two heads, which is better than one, and we kind of worked through a few things together to try and make the service better for men.
And I think for both of you, and it's something that Gateshead Health really strives for, is that equity in care as well. We have these certain benchmarks with women's breast cancer, and with 1 in 7 women being diagnosed with that disease, the statistics is very different in male breast cancers.
Absolutely.
Can you tell us a little bit about the kind of statistics, and how do men generally enter into our system?
So, I think that we've been very good as a kind of country in raising awareness of breast cancer, and we've got the screening program for females. We've got a lot of awareness and education, but 1 in 7 ladies get breast cancer, and of that, 1 in 100 are men. So breast cancer does affect men. About 1 in 1,000 men will develop breast cancer in their lifetime, which is rare, but it does.
Significant,
it does happen, unfortunately. And generally, on the whole, men present later than women. I think there's a lot more awareness, as we've already kind of said, with women coming to the service when they have a lump or a new pain or a change in their nipple. Whereas I think men, on the whole, because there is that, whether it's embarrassment or it's nothing, or I don't want to bother anyone. There's a lot of things, barriers, I would say, that go before a guy coming to our service. Obviously, men do not have a breast screening program because it is rare. But at the same time, you know, we encourage men to come to our service, and we're trying to streamline that from GPs, which is part of the work that Emily and I are working on, and raise awareness and try and get guys to come in at an earlier stage so that they're not coming in when it is a bit more advanced than women.
Yeah, and I love the fact as well that, you know, he's really trying to change that environment as well, you know, trying to get a little bit more neutral, you know, again, breast cancer is very associated with pink and, you know, and I think it creates a barrier, you know, when it comes to men, or, you know, finding that lump and thinking, what should I do with it as well? I mean, there's a lot of benign diseases as well with regards to males and their breasts as well. We see a lot of that, you know. You've got experience of that.
So when someone gets referred in from their GP, they come to a clinic and get assessed, and what we found is 1 in 20 patients who are getting referred into Gateshead Health are men, and on the whole, about 1% of those men will then be diagnosed with breast cancer.
Wow.
So it's still really rare, but, you know, for us, we want to see people who have lumps so that we can make sure that everything's nice and clear. We encourage ladies to come to our service with a lump so they can get reassurance or a diagnosis, and we should be doing the same for men.
Yeah, and again, it comes down to that equity as well. And, you know, we deliver such a fantastic service for the ladies. Is how do we flip that and ensure that those men get that same level of care? And, you know, Emily, you talked about the information needs for male breast cancer, and we really struggled with that as well. So what have you found so far?
So, I mean, when I did the audit, and what I did is I'd sent questionnaires out to all of the men that had been diagnosed in the last 5 years, and some of the statistics were quite, you know, very heavy on highlighting things like lack of documentation, that, you know, patient information that would refer you as a female and say, you know, she may need this, and, you know, when you examine your breasts, and it will be a diagram of a woman, things like that, and side effects, how it might affect your periods and stuff like that, which really, you know, it's not going to make a man feel very good, and
it's not really applicable to them, you know, and you kind of want to pick something up and understand that it's something for you, isn't it?
Yeah, and it kind of puts doubt in their mind as well, thinking, oh, well, has this been given to me by mistake, you know? And a lot of the answers that I got was all about the waiting area, very female waiting area, in the same room as women. Then the name gets called out, they feel embarrassed. A lot of it was lack of awareness as well. So there was a really high percentage of men in the audit that didn't even know men could get breast cancer. A very high amount of men that said there isn't enough awareness. I think it was about 90% of the participants said that they didn't even know about it before their diagnosis. They probably just went because someone said to them, oh, you've got to get that checked out, and a lot of them delayed coming because it never occurred to them that would happen.
I mean, things like breast diseases in men, we are seeing an increase in some of them recognising that that's not right, you know, things, breast diseases like gynecomastia.
Absolutely.
Can you give us a little bit more information about kind of the difference of how that would present as opposed to, you know, maybe a lump that we would be suspicious of?
So when men come into a breast clinic, there's a lot of things that it can be. It can just be a simple skin lump, or it can be gynecomastia, which is an excess of breast tissue. Now, yes, men get breast tissue. Some people might call them moobs, you know, and I think that might be a bit more derogatory, but certainly an excess of breast tissue can be caused by a huge amount of things, whether that's tablets that you take, whether it's age, whether it's a bit of excess weight, so a bit of obesity. There's lots of things that can drive changes in men's hormones in order to create a bit more excess breast tissue, called gynecomastia. Now, when you find a lump as a man, if you've got changes to your nipple, or some discharge from the nipple, particularly red or brown, or if that lump's quite hard, they're the sort of things that make us a bit more anxious, and why we would definitely want you to come to clinic. If you find a lump, what I would recommend is going to see your GP. They should be doing some bloods on you to just check your hormone levels. But if they are worried, what they'll do is they'll send you up to us and we'll get you sorted. And as Emily's kind of said, there's been a lot of issues with the information that we've provided, and almost every breast unit provides, where it's very female heavy. And if 1 in 100 of our cancers are men, we just need to accept that and make things more accessible to men. And that's changing how we host you in the units, changing what information we provide. And Emily's kind of redone all the kind of information leaflets in order to try and make it more male centric.
And personal as
well.
Exactly.
I
think that's something, you know,
personal care is vital.
And I think that's what it's about, you know, gender or sex or whatever, you know, it's what's personal for you, and you want to pick up that information, you want it personal about your health or your symptoms or your treatments, you know, because like I say, we're all short of time, and like I say, we want that accessible treatment as well. So, you know, treating male breast cancers, I think you mentioned there that they would have that triple assessment within the unit. If they then go on to find that it is a cancer, what tends to be the management after that part?
So, on the whole, what we've found is, and certainly what all the research shows, is that men present a bit later than women. Now, whether that's because women are more aware and it's more acceptable for them to go in, or they've been detected by the screening, they tend to present at an earlier stage than men. Men obviously have a little bit less breast tissue than women, so it means that their treatment tends to be not on par with how we would treat ladies. Now, when we talk about male breast cancer, it's a lot similar to female breast cancer in that men have about 90% of men have estrogen sensitive cancer, whereas it's a bit less in women. It's very rare for them to have other receptors, things like HER2 and or triple negative cancer, which is far more rare in men, where it's a bit more common in ladies. When we talk about how we manage you, there's, first of all, we have to kind of deal with you, and if it's a big cancer, on the whole, most patients go for surgery first, which unfortunately with men, as I said, with less breast tissue, it tends to be that most gentlemen go for mastectomy first. In women, where there is more breast tissue, we try and do what's called breast conserving surgery, where we do try to keep the breast and the nipple. And obviously going forward, about 90% of men do get mastectomy, which seems a bit high. And I think going forward there would be moves to try and what we call de-escalate treatment.
And by de-escalating, what would you mean by that?
So it would be, where possible, trying to keep the nipple, because as Emily kind of alluded to earlier on, there is a lot of physical change when it comes to mastectomy. You know, and even whatever age you are, there is a big change, and we know that the rates of things like depression afterwards is higher in gentlemen who have mastectomy than those that have breast conserving surgery. So that would be just taking out a bit less tissue and trying to keep the nipple where possible.
Maybe radiotherapy and things like that.
It would normally be followed up by radiotherapy. But given that male cancers tend to present a bit later or at a more advanced stage, it tends to be mastectomy first.
Which is what I suppose happens with women. You know, if you've got a small breast and you've got a large tumour, unless we can de-escalate it with things like chemotherapy, often sometimes the safest thing to do is mastectomy as well.
And as I kind of said, because it's most male cancers are sensitive to estrogen, which means that chemotherapy before your surgery tends to not work as well. With ladies, because there are more targets to treat with chemotherapy and immunotherapy before they have surgery, that's not necessarily available to men.
So there's obviously lots of treatments out there, and like you say,
Absolutely.
I think one of the things these have both said is that unfortunately men do tend to present with this a little bit later, so it kind of the treatments are a lot more toxic as well.
Yeah.
But you know, we still give men things like tamoxifen.
Absolutely. So men with their tumours being sensitive to estrogen, as part of their treatment we would give them endocrine therapy or anti-estrogen treatments, and we know that tamoxifen as a treatment which is used in ladies who haven't gone through the menopause yet, that is the most effective treatment in men, but it does come with side effects. So things like hot flushes, changes to your libido, and the compliance isn't very good. Unfortunately, men are less compliant than ladies in keeping their tamoxifen
But men
going.
don't talk about it as well.
Absolutely.
But then I feel like then us as professionals, we have a responsibility to bring that up, because I don't have, none of my male patients would ring me and say, "Oh, Emily, I'm having, you know, sexual problems because of the tamoxifen." That won't happen. Very rare. I don't know many male patients that would do that, and that's why we have a responsibility really to be asking the question
and giving them permission.
Yeah,
isn't it?
Yeah, absolutely.
because the thing is with women, you know, we are very open. We do talk about all these things. So why are we not doing this for the men? You know, we need to. They might be uncomfortable. They might shut it down straight away. That's fine. Let them shut it down.
Yeah.
But I think we have this responsibility as professionals. We need to be bringing up the subject, and to be honest, I think people don't realise that this can happen. They're so busy thinking cancer, they forget about afterwards what they're going to be left with, you know. And the non-compliance, it's a shame, because that could be improved if these things were discussed. There could be a way to address these issues and
as
concerns.
we do with women, you know, with hot flushes, the acupuncture,
the
CBT, you know, that there's some antidepressants that work very well with flushes, but again, it is very female oriented, which is great for the women who need that as well. But it comes down to that equity and providing that as well. And I think there is this responsibility on the patient side to kind of empower themselves, but also from a professional point of view, you know, that we're not just handing out treatment like Smarties, that it comes with that right. This is the why you're taking it, and people fully understand the why, and this is how we're going to take it. And providing them with those services to support them with that compliance as well. Because yes, we get rid of the cancer, but we want to give you good quality of life as well. And how do we do that? And I think, you know, publicising things like male breast cancer and, you know, what to expect really does help and gets people moving, you know, and partners checking partners and encouraging one another if it's something new. And
certainly the gentlemen who have, so men present earlier if they have a partner.
Wow.
So, you know, quite often their partner will be like, "Oh, go and get that checked out." So there is a protective element for those that have partners. And I think it's opening up that conversation to say, okay, men can get breast cancer. If you go on the breast cancer websites, it might be one page of that entire website is dedicated to male breast cancer. And yes, I know it's 1 in 100 breast cancers, but it is still an important population that's underserved, and that's what the work that we're doing is trying to change that.
Yeah, well, the tamoxifen booklet, you know, that I think one of the Breast Cancer Now booklets for tamoxifen, the paragraph, it's about that big for the men. Some men get these side effects, and it's not a true reflection of what men go through. You know, it should things like this, it should be recognised, it should be talked about. It's like, you know, when men do lose the nipple, we always make sure we tell them that they can have a nipple reconstruction, and that can be done, because really, how would they know? They wouldn't know unless we tell them.
I remember, you know, probably about 10 years ago, a gentleman who was maybe in his late 60s, loved swimming, you know, absolutely loved swimming, and he rang me and just said, "I can't do it. I really can't do it." He says, "The thought of taking my top off and for people to be looking," you know, and I think it's like, well, nobody.
And going on holiday, if you're a woman, you have a bikini or you have a swimsuit. With men, it's different. They go on holiday, they take their top off, you know, and that's where sometimes we need to be thinking outside of a clinical setting and thinking, you know, it goes back to that word holistic, doesn't it? It goes back to that and personal, and you know, after this they do need to go back to their life, and if, whether they're a swimmer or someone that holidays all the time, or someone that, you know, not to make anyone uncomfortable, but someone who has a very sexually active relationship with their partner, you know, things like this, all these different things all go towards someone's, you know, their life and their happiness. And we really, you know, we need to try and do everything we can so that we're not, you know, to their detriment, giving them treatment, but then essentially making it so that, yes, they're still here, but where's their quality of life?
Totally. Just, I think as well, Ross, you mentioned there about obviously that there is part of the population that's maybe a slightly higher risk of these male breast cancers than others. Can you just explain that a little bit more?
So when we talk about breast cancer in women, about 5% of breast cancers are genetic. That in men is much higher. So about 1 in 10 men who develop breast cancer, there's a genetic element. And there's 2 main genes. So there's BRCA1, which is more common in women in causing breast cancer, but it's actually a thing called BRCA2, which is in about 15% of men who get breast cancer. So it is a much higher percentage than in women. There are other genes that play, but certainly most men who have breast cancer, about 40% will have a strong family history of breast cancer, and that's normally within their female family. I think one of the biggest take homes for any man who's been diagnosed with breast cancer is, if you haven't had genetic testing, it'd be worth speaking to your clinical team about getting that. Basically, the NHS has recommended in the fairly recent times that all men with breast cancer, as a blanket term, should have genetic testing.
Right.
Because obviously that then has an impact on your family. You know, knowing that you carry a mutation might allow daughters or relatives to access earlier screening. We talk about screening in men, and you know, there's no clear program, but certainly if you had a family that was known to be BRCA positive, or you in yourself have breast cancer, you'd be eligible to have screening in the form of mammograms going forward. So it's just making sure that your clinical team is aware of your cancer history, and also making sure that you have been checked out from a genetic side.
Right, it's really interesting, and like I say, you know, if a male has got a lot of female breast cancers in the family, is that something just to be aware of as well?
Yeah, absolutely. So any, you know, first degree relatives, so that might be your mom, your sister, your daughter, you know, that puts you at higher risk of carrying a genetic mutation. And it might be that you are eligible for genetic testing even if you haven't had breast cancer.
That's really interesting. Again, you know, that's the great thing about genetic testing is that we're getting it early. And that's where we've kind of been falling short a little bit. So I think that's it's a great message, you know, it's really quite informative, and there's lots of it's really easy now for that referral to be made. At one point there was lots of
hoops to jump through, but actually, you know, if a man comes to me and has a breast cancer, I can literally just take your blood, run through some forms with you, and send it directly for assessment. You know, this process is streamlined so nicely. And as I say, you know, if you have had breast cancer as a man, make sure that you've had your genetic testing, because it does have an impact.
Yeah, and I think it's just reassurance for, you know, obviously cancer patients, it's often them, it's not really the concern about themselves, it's how does it going to influence
the kids and
so it's, and I suppose it's giving them a little bit control over that, and doing something is a protective means.
Because it might mean that if you had a daughter, for example, she might be able to access screening, so that she makes sure that she doesn't have a breast cancer earlier than she would otherwise.
So ultimately it saves lives,
Yeah,
doesn't it? And I suppose,
absolutely.
you know, if it was a cancer to happen, then, you know, treatment is so far different, finding it, you know, at stage 1 as opposed to a stage 4, where we see a
Absolutely.
lot of these male breast cancers as well. And, you know, I think it's tremendous the work that you're both doing. You presented this recently at our Breast Aware Day, and I think it really kind of highlighted the issue, especially small things like the waiting room and, like I say, the information packs.
And now we've got posters up that actually have, you know, Blue Get It Too posters in the waiting room, and you know, within a few days there was patients coming in going, did you know men can get breast cancer? Well, yes I did, because I put the posters up. But you know, they'll go home and probably say to their husband or partner, and they'll go, did you know that men can get breast cancer? And that can be, you know, and it can have like a domino effect, and you know, you are hearing it more, and this is the whole thing that we're trying to break down is, you know, we want people to be aware, because early is key, you know.
That's great. I mean, the information he's given today has certainly been food for thought for me, and how I deliver, you know, a service. But you know, that's great, and thank you so much for coming today. Is there anything else you?
No, just thank you for having us, Caroline.
Yes, that's great. Thank you, and you know, and good luck with the future, Ross. I'm sure by the time you come back, you'll have a few more extra.
Already there.
Thank you very much. Thank you.
Okay, thank you.